عايزين بس البوينتر. Good evening. My name is Nesma Naguib, a resident at University Hospitals. I was talking about female imaging cases, interesting cases. My first case is a 33-year-old female patient come to the ER with severe recurrent vaginal bleeding after cesarean section. By examination, there is a neovascularization at the site of cesarean section score. Patient resuscitation was done with all measures to stop bleeding, reaching intrauterine tamponade with no improvement. MRI was requested. Those are MRI images. The first image here shows the uterus with a tamponade, and we can see here abnormal tortuous blood vessels or signal void, flow-related signal void. Here we can see in those images abnormal tortuous dilated blood vessels related to the site of cesarean section scar. We can see it in coronal images, and it's signal void in both T1 and T2 weighted images. Those are abnormal dilated blood vessels. And now we do dynamic images to understand from where to where is it. In the first minutes of the dynamic image, we can see early enhancement of those blood vessels, which denote an arterial site. And in the 8th minute, we can see the whole uterus take the contrast, and we can see those abnormal dilated blood vessels. That means that early wash out of the contrast. That means it have a venous side. So we can see we have a post-traumatic arteriovenous lesion. This is a subtraction image. We can see the same arterial enhancement in early first, second, and late washout. So we are suspecting arteriovenous lesion, which is even arteriovenous fistula or arteriovenous malformation. To differentiate between them, we have two things. The first, the clinical history. Arteriovenous malformation is a common congenital problem, not acquired, not iatrogenic. This case is post-cesarean section abnormality. So we think about AV fistula, and to be sure, digital subtraction and geography is done. Arteriovenous malformation, there is a nidus between arterial side and venous side. Arteriovenous, there is no nidus. This case referred to the interventional radiology unit, and embolization of the bleeding vessel done, followed by dramatic improvement of the case, and the patient discharged shortly after this. This is my first case. Second case is a 19-year-old male patient come to the sonomammography unit with a breast lump. In a male breast lump, we are thinking about the benign causes, which is more common, gynecomastia and pseudogynecomastia, lipoma, fibrolipoma, fibroadenoma, and intramammary lymph node. And we can think about malignant causes too, like breast cancer. The differentiation usually by ultrasound and pathology, but we are talking about, this is the ultrasound of this male patient. We can see a localized, well-defined area of hypoechoic lesion in the left breast. The take message here that unlike female lesions, a well-defined margins of a lesion give it more suspicious than an ill-defined. And a deep lesions are more suspicious than subarachnoid lesion. This case is a fibrolipoma by pathology, okay? And just to put in your mind that a well-defined lesion is more suspicious in male breast lump. Thank you.